Hello and a very warm welcome to you. My name is Ray Lavery.
My name is Jessica Crooks.
And together we manage and run Trans Matters Worldwide and Trans London Meetup Group.
We do in-person events and online events once or twice a month. And right now we're hoping to move into webinars. We're bringing in experts and trying to educate.
That's it. And so originally this channel was actually my female to male transition line, but we have upgraded it from there. And as Jess has said, what we are going to do is we are going to do all things transgender. So there'll be fresh webinars, there'll be fresh interviews, there'll be some fun stuff if we can think about it and just record it, and things just to keep you occupied and have some fun and help you along your transgender journey. So to make sure that you don't miss out on anything, all you have to do is hit the subscribe button, and that way you will get all of the notifications of what we have coming up and you won't miss out on anything. So enjoy that and we will see you in there. So take care and goodbye. Okay, recording is in progress. Right. Hello, a very warm welcome to you all. It's brilliant to have you here. It's also equally brilliant to have the wonderful, the very wonderful Mary Burke from the Gender Hormone Clinic, who is here doing her third installment with us on basically everything hormone. So we've been through MTF, FGM, and now we're going to do non-binary. We feel you guys are a group that's massively left out, and that is unacceptable as far as we are concerned. To me, you're actually the bigger group, so we are delighted to be able to welcome you here today. We're also very delighted to have the wonderful Kat Egan. Kat herself is non-binary, so she, they, isn't that correct, Kat? Have I got that right or wrong now?
Yeah, she, they, or they pronouns are good with me.
Oh, thank you, because I was just about to sweat thinking I got that wrong there. So thank you very much for that. Now, Pat also works with Mary as well, so she's extremely well versed on everything that's going on here. So her participation, or their participation today, is going to be very much on their experience on hormones, obviously from a non-binary perspective. I also, again, of course, the wonderful, who I wouldn't be able to do anything about, the wonderful Jess Crooks, who runs the meetup group with me here and is responsible for a lot of the ideas and a lot of the running of the stuff that we are doing here. So Jess, as always, warm welcome, and thank you as always for all of your support and everything that you're doing for the group. It's amazing to see the group has grown from strength to strength. A year and a half ago, we were 150 people. Now we're like 236 or something like that, something around that. And it's growing more and more every day. And we cannot wait to help you guys. We have so many more of these webinars coming up. But before I go off on a mad rant, hello from Plymouth. Yes, hello from Plymouth. You're very welcome, Plymouth. So today we're going to talk about the A to Z for hormones, obviously for non-binary. What we're going to do is we're going to ask Mary an enormous amount of questions, but what we would like you to do as well is also put your questions in the chat, put them in the Q&A, and when it is appropriate, we will get to them, and we will rudely interrupt Mary and ask her these questions. And we know that there's nothing out there that she can't answer. She got annoyed at me last time when I called her an expert. She said, "Listen here, I'm not an expert. I'm not an expert."
It's a lie. It's an outright lie.
I'm an expert. So brilliant stuff. So Mary, maybe if we start with you, if you just want to do maybe a little introduction to yourself, and so everybody knows who you are, because I'm sure not everybody has been at the Gen Dog as well. Sorry about that. So yes, tell us a little bit about yourself so everybody knows what's going on and who you are.
Okay, so I'm a nurse specialist really, and I started working in gender healthcare in 2009, initially on the surgery side, but I have a vast amount of knowledge. I've been a nurse now for more years than I care to remember: general nursing, midwifery, family planning, sexual health, general practice, I started prescribing in 2008, working with women in the menopause. So I was fairly au fait with hormone therapy. And then I started working with Mr. Inglefield in 2009 at the London Transgender Clinic. And that was when I was first introduced to transgender individuals for the first time. I've always been amazed and how brave my patients are. And how grateful and thankful they are for the care that they receive. Wonderful, amazing group of people to work with. And I've always loved empowering people and enjoying doing it, you know, having the crack, as we'd say back home, always, you know, because it's so important to lighten the load for everyone. So my passion since 2017, end of 2016, 2017, I started prescribing and set up a hormone service for transgender individuals, non-binary individuals, anyone really, anyone in the gender spectrum really. And we treat everyone individually. I mean, I've been in clinic today, I've seen 7 patients, and every single one of them so different and so interesting and challenging and you know, and great. And that's, you know, that's what we love doing. 1st of February, we moved premises and set up as the gender hormone clinic rather than with the surgery side, the London Transgender Clinic. And we work in Fitzrovia Hospital now, Fitzroy Square, in London. And, you know, I have 2 patients, 2 Irish patients today, actually, one from Northern Ireland, one from Southern Ireland, and some Northerners as well. So really interesting. So we see everyone, we welcome everyone, we try and help everyone, and that's all we do. And I'm not an expert. Stop it. Do you know? I'm constantly learning. And I'm off to EPA, the European Professional Association for Transgender Health meeting, which is going to be held in Killarney, which is going to be a lot of fun, a lot of crack again. Here I go. This is it now. The end of April to learn more. Yeah, because we're always learning. We learn from our patients and we learn from each other as professionals. So really looking forward to that. So hopefully I'll be able to bring back some interesting news and updates from that. So that's me, guys. That's me.
Yeah, it's great. And you know what? Because obviously I know the EPAT is coming up as well. And I'm hoping there's going to be a lot of conversation around non-binary. I mean, obviously there's been a lot of conversation over the last number of months, years. Particularly anybody going through the NHS and attempting to get any sort of assistance as non-binary, where they have been more or less blocked, or they have to do some very serious convincing, or pretend that they're actually going to go for a complete change of gender in order to get any sort of hormone therapy whatsoever. And to me, that is an absolute disgrace that the people who are there to help us are not even understanding the basics. It's not like non-binary is new. It's not new. It's not, you know, it's not new at all. But it hasn't had the visibility. And what I would like to see is that there's a lot more visibility here, because to be honest with you, I've learned the most from non-binary people.
Yeah.
They have been the ones who have taught me the most. And I feel who also have to take the most as well. You know, for a lot of non-binary people, it's going to be well, it's not really the idea, but a lot of them will never, as they would say, pass, because that's not where they are going, which leaves them in a little bit of a sort of another version of the middle, where they don't get the acceptance, where people like myself can go stealth, because right now nobody can tell anymore, you know. So I have the great respect, and like I said, I have learned the most, and anybody who's non-binary has taught me significant amount, because I had to rethink how I thought gender because of what I learned from non-binary people.
Yeah, for sure.
And that's amazing. That's amazing. So let's get sort of the basics out of the way if we can. So obviously we're talking non-binary, and there's many different varieties of non-binary, such as it doesn't mean that you want to be agender or smack bang in the middle. You could be he, they, or she, they, and so on. So therefore, where you're going for physically can be very, very different, and it's very, very individual. But if you took it at the very basic form, we obviously have somebody who was assigned male at birth, or somebody who was assigned female at birth, who doesn't want to be seen as that, as a key. So for people in that spectrum, what is the best thing to do? Maybe if we go for the assigned male at birth first, what are their options when it comes to hormones?
Well, generally, I suppose patients will come to us when they've decided that they're not happy the way they're presenting, because, you know, as non-binary, you can, you know, you're not binary. You understand you're not male, you're not female, but you can, you know, you don't have to have hormone therapy. You can just present as non-binary, dress in whichever way you like and present socially. But as Ray rightly said, that can be difficult. Yeah, okay. And I always, and there's always this big discussion as well, you know, about kind of pronouns and things. And I always say, look, Jesus, you have a name, you know, use your name. And we all have names. I'm not religious, God. And I'm just, but, and, you know, I learned a lot. As Ray said, you've learned the most that you've ever known from non-binary individuals. And that's how I learned, because I struggled initially when I started with, you know, with prescribing for patients. And I used to ask them, what do you mean? Tell me exactly what you mean, because I need to understand exactly where it is you want to go, how far you want to go, what it is you'd like to achieve, you know, and try and explain that to me first, and then I can try and help you. But if you have an assigned male at birth and they're coming in and they're saying, well, you know, I'm non-binary and I'd like to present, you know, slightly more femme, well, that's not a problem. We usually start them on estrogen. And we start all of our patients who come in, if they're assigned male at birth, non-binary, that's why they're coming, because they want to present slightly more femme, okay? And some of my patients will, they may like to take things a little bit slower, yeah? And that's absolutely fine. Take your time. There is absolutely no hurry. You know, they might come back in 6 months, they might come back in a year, and they might say to me, you know what, Mary, and I always ask every time patients come to see me, I will say to them, so tell me how you identify now. Has anything changed? Yeah, because sometimes it can, because hormones are so powerful. Lots can change. Your preference for your partners may change. You know, psychologically, hormones change you. So maybe initially you may present as non-binary. You may continue to present as non-binary, or you may not. So, you know, when we see patients, we always have that discussion. And the plan is that we get you to where you want to go safely. All right. So we'd always start on estrogen. Then, you know, if they want to see if they're feeling comfortable at 6 months and they want to block a little and see how they feel, but they may like to maintain a little bit of erectile function, we can do that. A year in, you know, if they'd like to try progesterone because it has many, many wonderful benefits to it. And indeed, I had a very interesting case yesterday. Maybe it was earlier today. It's kind of all blending now. But, you know, where I changed a patient's prescription who'd been under someone else, and, you know, their whole life has changed for the better. And they're excited about life, you know, again. So it's fascinating. But I will never say, you know, this is what you have to do. Yeah. I always say, what is it you want to achieve? Okay. And then let's see how we get there. All right. Safely. All right. And it just takes time. And there's no one size fits all in this business. There really isn't.
No, there never is. Even if you're FTM or MTF, there's no such thing as one size fits all. No. So when you're saying starting on estrogen, because I know that this question is going to come up, so we might as well sort of deal with it now when it comes to estrogen, is microdosing. Now, a lot of people have a lot of questions about microdosing because, you know, there would be, if you like, a standard prescription, if you like, that you would start somebody MTF or FTM if they were going on testosterone, but then microdosing is something else entirely. So where do you start a non-binary person, and how different, I guess, is that to somebody who is going either FTM or MTF?
It's not hugely different, because all you do is you just say to the patient, look, you know, do you want to take this nice and slow and see how you feel? Or, you know, do you want to just try with our kind of regular routine and see how things go? Generally, you know, because we have a video link consult with the patients for an hour before they ever come into clinic to get their history and have a chat with them, you know, go through all of that. And then when they come into clinic, you meet them and you sit for another hour and have a conversation. And it's a very casual conversation. It's like sitting with a friend and saying, how can I help you? What's the story? Yeah. And at the end of the day, you've kind of figured out what they want. And then you decide. And yes, you can start with a little, all right? And that very much depends. You know, the dosages will depend on whether you're starting them on a patch, which you could, a low dose patch. You could start them on a low dose gel, or you could start them on low dose oral medication once they're under the age of 40.
And have you a preference as to which one you prescribe there?
I always prefer Sandrina gel. I'm a Sandrina gel fan.
Why? What
Big
is it
fan.
about that is better than,
Because
in your opinion?
you get respectable levels. It's transdermal. You rub it in, it dries in second. Job done and dusted. You don't have a sticky patch on your anywhere on your physical body where you get. It's like you have a plaster on for a few days. You get this awful black rim around it, and it's obvious to people that you're on something. Especially if you're sexually active and you've got a patch on your backside or something. It's
So this,
other people. And I don't, oral estrogens have never been. I don't prescribe them to anyone who smokes. I don't prescribe them to anyone over the age of 40. And I think it's good to get people into good habits. And rubbing on a little transdermal gel is kind of healthy. You get good levels. And I could start, if I had a non-binary patient, I might start them on 0.5 milligram of Sandrina gel and see how they get on. Touch base with them maybe after 3 months and say, how are you feeling? How are things? Whatever. And they might say, do you know what? I think I'm ready to maybe up the ante a little and I'll up my dose and then we'll review again at 6 months.
And sort of like you said, 0.5 millimeter. Is that what I heard you say?
0.5 milligram.
Oh, 0.5 milligram, right. And sorry, milliliter. So, I mean, what would that be in relation to if you were prescribing somebody sort of like FTM?
Oh, well,
MTF, I beg your pardon. How would that relate to?
I would generally start on 1 milligram and then up it after 3 months to 1.5. Do you know, I had a patient like that, very lovely patient, and they've been a patient since 2018. And they started on something tiny like that, and they were on it for like 2 years. And after 2 years, they upped it a little. And it's only recently they've actually decided, do you know what? I'm actually female. I'm not, and that's like, 4 or 5 years. So take your time, don't push it, and see how you feel. Because some non-binary patients, they might not want to start developing, breast tissue, but some people do that a lot quicker than others. And, you can't stop that happening. Yeah. So you don't want to rush in. And then, although in fairness, most patients, if they get an A cup or a small B cup, that's as far as it goes until you start increasing doses that bit more. But I always explain to my patients, look, things may, even on a small dose. I had a patient on 2 milligrams of oral estrogen, which anyone who's taken oral estrogen will know that that's a really low dose of oral estrogen. Yeah. Like it's just the lowest for the low.
Yeah.
They were self-medicating for 5 years. This is a trans female, came into me early 50s and she had D-cup chest. Now that's a good size. And she was actually really upset with me when I thought she'd had implants. Yeah. Because I thought there's no way on that dose this is ever going to happen. But it does. So for my non-binary patients, I say to them, look, take it slow and see how you feel. Yeah, because you've got time. Transition takes up to 5 years. If you want to just remain, and you're going to identify as non-binary long-term, that's cool. But you don't want to get to the stage where you're developing, changes that you can't change. And it is the chest that will bother most of my non-binary femme patients, because they want to present as femmes, slightly more femme, but they don't want to develop that much of a chest. That they would tend to see, they find more disturbing.
All right, so take it easy, go slow. And so on that breast development thing, so I mean, obviously your breast will develop based on the amount of estrogen and how your body is absorbing it and so on, which is of course the thing. So would it not make sense to slow it down, that you could just come off the estrogen for a while? Would that stop it? Or so once you've started that train, that's it?
Yeah, well, of course you could. But, then, psychologically things change when you stop your hormones, and that's not nice either. And that's what people miss most, I've had patients come to me and start hormones like that. And they were non-binary and they were, concerned about, but they really miss that feel-good feeling, that, peace they find. And we've spoken about it before, both Jess and Kat and, even yourself, Ray, have mentioned it, the impact that hormones make and how life-changing they are in the first 6 months, especially for, our non-binary femme patients, because psychologically they start to feel a lot more peace. And that's where most of the changes happen in the first
Yeah,
place.
and really for, I mean, I think with a lot of non-binary, it's about, I mean, for everybody, any changes are for you. It's not for the outside world. It might appear like it's for the outside world, but it's not. It's for you. It's for what makes you feel good in yourself. And you know, the three of us here, myself, Jess, and Kat, have talked about this on previous ones about just feeling calm. Just thank God we're here now. Let's just all take a chill pill, you know. So, Kat, do you want to sort of jump in here, because obviously, did you start on a lower dose then? Is that where you started as well?
Yeah, but it was less intentional. I was also just going to add as well, with breast development, it isn't just about dosage, it's also genetics. There's elements of if you're genetically predisposed to having a larger chest, you'll develop more breast tissue. And also it depends on when you're starting. There's a lot of other factors too. But when it comes to my own, because I started on I went through a NHS adjacent route, using the NHS as a bridging prescription kind of thing. So for about the first, I think it was first 2 years of hormones, maybe first year and a half, I was only on 2 milligrams, kind of not intentionally, more just because my practice were having some, how to put this diplomatically, they were reluctant to increase dosage to match the levels that they were given. After a while, it kind of convinced them, and I kind of still saw more significant changes. If anything, the biggest change that I had happen post increasing dosage was more mental health wise, rather than it came when physical changes. Because by that point, about like a year, 2 years, you're starting to see more visible physical changes with transition anyway. So it was less that things sped up a bit more, and more that a few more things kicked in as they were supposed to, and my mental health adjusted as well to a more balanced state and stuff like that. So it was, it was more interesting. But it was the transition path going through the NHS and trying to get hormones as a non-binary person anyway was kind of a bit of a nightmare. I initially went to my GP 5-6 years ago now, back in 2017, and I tried to get them to prescribe me to the GIC at the time. I was telling Mary this literally 2 days ago.
Yeah.
And I came in and I was very androgynous presenting. I was in a kind of like bralette with like skinny jeans as tight as anything on, kind of very, very androgynous kind of presentation. And the GP kind of told me then and there I wasn't presenting feminine enough, and they would not refer me until another 2 weeks. If I came in, I needed to book an appointment again in 2 weeks to come back in and be re-reviewed before they'd even refer me to the gender identity clinic.
You were lucky that was only 2 weeks. I've heard much longer things. Yeah, this is where you have to dance. You have to pretend, which is the most ridiculous thing on the planet.
Yeah, so I then had to do this kind of this pretend with them, where it was very much you either want everything or you want nothing. So you're either going to go fully feminine, like every single thing is going to be, you're going to be the most feminine, like femme person ever. It's floral dresses, the works, or you're getting none of the healthcare kind of thing. So it was very much this gatekept thing where I had to then go into this more performance of a binary idea of gender that wasn't really suitable for me.
Right. So they just basically, they were like, nah, we can't understand anything that's not binary. And so unless you play, that's it. And this is what we hear all the time. And I know that there are, by the way, a lot of very good health professionals who do not behave in this way. But the GIC, let's be honest, they're terrible. And even the rebranding of it, that's the same thing under a different name. I don't think that's made any difference whatsoever. So it's, again, wonderful to see more and more non-binary people coming in, because that's exactly the education that is required in order to be able to do this. Now, look, there's a lot of questions coming through. By the way, we see the questions. We know that they're there. Jess will get to them in a minute. I just want to sort of get the basics out of the way. And there's some very good, very different questions that have been asked this time. So please bear with us and write them down when you think of them. So great. That, you know, what you're describing is kind of where I was thinking of that. So Mary, just back to sort of the dosage for assigned male birth here. So we have estrogen at a low dose, so half what we would call the normal dose. See how we're going. Review again in 3 months. Now, you also mentioned progesterone for non-binary. And actually, I have not heard of anybody who is non-binary on progesterone before. So can you maybe outline that a little bit more? Explain that bit.
Yeah, I mean, it's both males and females produce progesterone. Okay, so I always give the patients, you know, we don't initially, we always will wait 12 months in, 18 months in, you know, and see how they're doing, how they're progressing. You know, if they want to, you know, if they're non-binary femme and they'd like to present slightly more femme, you know, progesterone can kind of calm the waters. It suppresses the central nervous system, so it has natural anti-anxiolytic, antidepressant effect, but it also, you know, has a positive effect on your lipid profile. It has you know, a positive effect on brain and heart tissue long term, and other beneficial effects. So, you know, it's not only about helping to develop and round out, you know, breast tissue, but it has lots of other very beneficial effects. So I always say to patients, I have a conversation with them and say, look, you know, this is something else that we always discuss with patients. If it's something you'd like to try, we're very happy to try again and see how you feel on it, because it can be life-changing for some patients and stabilizing. So, you know, I have a conversation, because in order for patients to make any choice, they have to understand, you know, what possibly could happen. Yeah, what are the implications for them? And when you've had that discussion, then, you know, I'd say to the patients, well, you know, is it something you'd like to try? You may not stay on it long term, but you may find it helpful. If you don't try it, you'll never know. It's like with any form of medication that we start. You're never going to know how one individual is going to react compared to another. As we keep saying, you know, one size doesn't fit all. But I will always give patients the opportunity to take progesterone if it's something that they'd like to take. You know, I'm happy. I have weird and wonderful conversations with patients, and sometimes patients will say to me, "I'm paying for this service, so you need to give me what I want." And I'm like, you know, I don't mind asking, but do you know what? Unless there's an actual indication for you to be taking more or less or whatever the hell, I'm not going to, you know, I'm not going out there with you, because if there isn't a reason why it's going to make a damn bit of difference to you, or if I don't think that it, you know, it's safe to do so, you know, I won't do it. And they say, well, why am I paying to have it done privately? I said, you're paying to be looked after. And I said, I won't have patients telling me what to do. If you want a refund, take it and go elsewhere. Absolutely fine with that one too, you know. But I'd have some very interesting characters come in and tell me exactly what they want and write it down and give it to me. Well, no, that doesn't work, I'm afraid, either, you know, because we have to work within a certain amount of guidance. But I do believe in educating patients, talking to patients, giving them time to decide what it is they would like to do once they've heard the evidence, and sending research papers to patients and saying, have a read. Yeah, you know, read.
I think it's very important. Again, I think these timelines and this stuff on Reddit and on Facebook groups where everybody's almost bragging, well, I'm on this much and I'm on that much and all this kind of stuff. It's completely individual. It's incredible to me how different every single body is. And I mean body as in physical body, not just a person. It just blows my mind how there really isn't a standard. There's an idea, but the reality for each person is completely different. And you have to take that into account, and you have to bring a large dose of patience to all of this, because it's not something that you can just jump into feet first, regardless of, you know, how convincing somebody else was. you know, this needs to be properly done, and you can get yourself into some serious trouble, like life-threatening stuff, and that's unacceptable, you know. Now, I mean, I know the dosages will be an awful lot less for non-binary than they would be for MTF and FTM, and so there's less chance of that happening. But again, you just don't know how a body's going to react to it, so you've got to be careful. So leading from that one, I mean, look, obviously, if you're, we will move on to the sort of the assigned female birth in a second, but you know, blood testing for non-binary, and also the effects of the naturally occurring testosterone. Would you not need a little bit more to cancel out the testosterone, or like how does it work? Because I mean, you could be on an estrogen level and the testosterone is going, now I'm stronger, I'm going to keep in charge here, basically.
Again, Ray, it's a conversation, and it's a conversation, of course, that we have with patients, but you know, we never block until 6 months in anyhow. And I never jump in with anything, because you know what, if you throw everything at someone, they don't know whether they're coming or going. You're not giving them time to their body's time to adjust. So, and blockers come with their own set of possible complications, which may not be so nice either. So, you know, take your time, gentle approach, and you don't have the problems. Yeah, you'll always have patients that are maybe more anxious, and I tend to find that more so in my non-binary transmasc patients, because, you know, their voice can start to change within weeks. And all of a sudden, you know, I had a patient 3 months in, and they're like, gee, Mary, you know, my voice is really changing. I'm getting a lot of body hair, and gee, you know, and they're only on like, you know, half dose. So I said, well, look, we'll go down to quarter a dose, slow things down, and get back to me in a few weeks and let me know how things are going. So instead of being on 40.5 milligrams, say, of Testogel, they were on like 10 milligrams. Now, I know some postmenopausal females on 10 milligrams alternate days, you know. So you can really bring their dose down to slow things down. And some of them have come back and said, you know what, I think I might take a break and just reassess the situation. I tend to find that more so with my non-binary transmasc patients, because testosterone can change things quite quickly. You know, I used to have a pump here. I don't think I have one of the Testogel pump with me now, but I used to show the patients, you know, I used to say, look what it's like. And I put a little bit on, and, you know, rubber in, and they'd look at me. But if I had, you know, 7 patients a day and I was rubbing that in, 2 days later, I'd be like, you know, honestly, and that was a small amount. So it can really make a difference. So I always say to patients, if you start getting uncomfortable on this at all, just contact us. We'll have a conversation. We can just slow things down.
So slows a thing. And so 6 months at least before blockers are put in. Is that usually Cinerel that you would use?
That's what oh no, Cinerel, no, I don't actually know if that's any longer on the market. No, we have an assortment. I'll try everything and anything, and after a conversation with the patient. So we'll prescribe injectable blockers. We prescribe cyproterone acetate at the recommended level, which is less than 10 milligrams daily. So we actually prescribe 12.5 milligrams alternate days, and it works incredibly well. Some patients only need it twice a week, some patients even once a week, just to take the edge off. Spironolactone isn't one I use in my younger patients. If I have a slightly older patient who just needs a titch blocking and their blood pressure's up a wee bit, then I use a small dose, you know, but I probably have 2 patients out of thousands on it, honest to God. And then, of course, bicalutamide, which blocks the testosterone receptor, instead of blocking the production of testosterone, it blocks the receptor. You can use that as well in different patients. So there's lots of different ways to tackle it. And I'll always have a conversation with the patient. And it depends on other medications that they might be on, interactions with polypharmacy, things like that. You know, so there's a lot to be taken into consideration.
Yeah, a lot. Okay, super. So am I guessing here that, certainly by the sounds of it, that you go for non-binary much more on how a person is feeling than their actual blood levels?
Yes, absolutely.
So do you do blood levels with non-binary?
We do them anyhow. Oh God, yes, we do. We do them anyhow, you know. because you just want to make sure too that the patient's reacting safely and you're monitoring them safely. And if you're sharing care with GPs, GPs want the reassurance that everything is okay, especially if they've not done it before. It's understandable that they don't understand it, and they're always going to worry about litigation and that. So it's nice for the patient to see what's going on. It's nice for the GP to understand and see what's going on and to safely monitor patients. But long-term blood testing of patients who are settled and well on the hormone therapy, after 2-3 years is not necessary. Just like I always say, postmenopausal females never have blood tests done. They're put on medication due to symptoms, and then they're left on it, and they never have a blood test. So once you're stable and steady and you're well in yourself, you're not on multiple polypharmacy of any other complications, then you shouldn't need annual blood testing after a period of time.
Right. And it's kind of good to hear, because you do get a feel for, because I know a lot of people who are freaking out, oh my God, my levels are really low or my levels are really high, yet they're progressing. And so, you have to take a chill pill, again,
Yeah,
these timelines are terrible for giving you bad advice on this stuff.
Yeah, no. And some of the younger nurses I work with, they'll say to me, Mary, their level is only this. And I said, well, look at the patient. For Christ's sake, they've got a mustache and a beard. Jesus, that didn't happen by chance. That happened because they're actually taking testosterone, So, look at your patient, all right? How is the patient feeling? How are they responding? That's why we like to spend time with patients, sit and have a conversation. That's why it's nice to have a face-to-face consult. It's not the same as seeing someone,
yeah, I like this. I mean, look, I know that's the way that you do things, Mary, but it's so important, because the 10 minutes with your GP, where they're just sitting in front of a computer tapping away, they don't talk to you anymore. So it's very important that you have these conversations, but also that you can have the right information to bring back to your GP when they're freaking out because of blood levels, or you haven't done your bloods. And I'm not prescribing this because you haven't had your bloods done in 4 months or whatever the case may be. So it's a big thing. So moving on, because we have already, I guess, talked about it. Or we have already talked about it, rather, is the those who are going to become more masculine, so the transmasc side of things. So what we're talking about here, am I right in saying that what you're talking about is, again, a half a dose of testosterone to start with, which would be 1 pump of the Testogel, which is where you start everybody. Is that correct?
Well, I mightn't start everyone on one. Some of them who say, I really want to go slow. Okay. You would start them on like half of one compression. Yeah. So you're talking about starting them on a quarter of a dose that you would start any other. And it would always be the gel. Yeah. You'd never be injecting Testosterone, or you'd never be injecting Libido. There'd be none of that going on. You'd be starting on the gel, and you'd be starting on a low dose. And I always say to patients, if you start to feel like, maybe things are going a bit too fast for you, even on one compression, then reduce it to half a compression. Yeah. And take your time. All right. Take your time.
And you can always up the dose if you need to, but going
Absolutely.
back down when changes have happened, and there's a lot of questions that are asking about stuff like that, which I know Jess will get to in a bit there. So, okay, so we start easy, and basically the thing is you need to know in yourself what's going on, and where you're sitting, and make a sensible judgment. But please, never ever up your dose on your own. Don't do that. It's okay to take less, but don't up your dose on your own. That could lead to some very serious effects. So please don't do that. Even if you just go, I have loads of bottles here. Don't do it. Get some professional advice, because things can speed up very, very quickly. Very, very quickly. So is that fair enough? I hope so. Rant over. Apologies on that. Do you want to get to some of the questions? There's some very good questions there, Jess, that have come in.
Let's do it.
Yeah.
So okay, we'll start with so are there changes that are irreversible coming from an assigned female at birth perspective, whilst we're on the topic?
Well, yeah, if you start an assigned female on testosterone, it's an interesting one. I think therapists always worry when we have our MDT meetings. Therapists always worry about, you know, the changes and how patients are going to respond to them and how the irreversible, you know, in this day and age. Okay, so you look at hair growth, all right? Well, you have for a non-binary transmasc patient, well, you've got laser hair removal, you've got electrolysis. I mean, we could easily get rid of raised beard form. It wouldn't be a problem, you know? So, I mean, I know you guys have done, you've done your webinar on, you know, vocal coaching and that. Well, yes, you know, if an assigned male at birth can change their voice, okay, through exercising and all the rest, well, you know, it can, I'm sure, work the other way. It's probably not, because I know it's very difficult for our trans female patients. So it's not easy, but it can happen. The other physical changes, once you stop testosterone, will resolve. Like your muscle mass will go down, your body fat, you know, will go back, because generally your estrogen levels will kick back in and you'll start menstruating within months, you know. So it's about, you know, hair growth, and it's about the vocal changes, and the vocal changes would be a difficult one to deal with. Yeah, but
it is possible though.
But it's
I've seen lots of
possible.
people do that. Yeah, but
Yeah.
it is. Look, here's what I say to people: is like, if you are even going for non-binary, because you don't know what the effects are going to be, assume that you could get a full FTM version. Okay, you could get a beard, you could get chest hair, you could get your big muscles. But believe you me, the big muscles only come when you do press ups and weights. You get a certain amount for free, but not enough to have that six pack and a beach body. Don't let anybody think that testosterone is going to do that for you. It ain't. You got to get out there and you got to work for it. So, but you are a little bit stronger. The fat distribution for me on a full dose after a year and a half on a full dose of testosterone only starts to kick in then. Yeah. Only then. And it will revert very, very quickly. So vocal changes. I mean, look, for me, I could hear vocal changes within a week. It took 6 months before someone said, have you got a cold? So they happen much slower to everybody else's ears than they actually happen to yours. It doesn't mean your voice hasn't changed. It just means it's not noticeable by anybody else. But the vocal training can do a huge amount of good on that. And we actually, our next one after this will be the non-binary vocal training that Stephen will also do as well. So we'll run through everything on that. So, you know, the changes and stuff like that, they're slow. I would say that I've seen a lot of people reverse their changes if they change their mind. Slowing it down, that's something else. But eventually, if you keep taking the hormones, you're gonna get there. You know, they're gonna, you know, you're gonna have changes. Which ones you have depends on your genetics, depends on how much you're taking, depends on a lot of things. So everybody is literally an individual on that, you know. And Mary's nodding, which is good, because usually she goes, I'll stop you there.
No, it is. And that's the lovely thing, you know, everyone changes. As long as you feel safe in the changes and you're not feeling rushed, it's better to just take your time. And I always say that to patients. We're always here if you have a question. We'll always get back to you. Just take your time and play it safe. Yeah. You know, and for patients, sometimes if they're non-binary, they're maybe doing it in stealth as well, and they want to take it slow because of maybe the social situation that they're in, the family pressures or whatever. So, you know, have to kind of be aware of that as well.
Yeah, sure.
One of the questions we get in the group all the time, and it's come up here as well, is a low dosage less effective if you're starting at sort of an older age?
Not necessarily. Again, it depends on the individual. But what I always say, I had a lovely, slightly older patient in today, although they were younger than me, but slightly older than you lot. But I'm older than feckin' everyone these days. Oh
no, you're not. No, you're not.
But I love it because I can always give out to everyone. I say I can do whatever I like because of my age, you young whippersnapper. Anyhow, but God, Jess, what was that question? Do you see if I go off the point at all? And I'm just like,
are low dosages less effective as you get older?
Yes. So yes, as you age, things tend to, it's just like you do surgery, healing is slower. So the body can be slower to change for sure. So that You know, as a rule of thumb, yes, that is true. Okay. But again, you know, people surprise me. It's like Ray says, you know, if you put someone on, if you microdose on, say, testosterone, and they're going to the gym every day and they're really fit and they're eating well, well, they'll actually probably change a lot faster than someone who's on a lot more testosterone and sitting on their arse doing nothing, you know? So it very much depends on the individual too. Yeah.
So the first step for anyone going to after sort of assessment from the clinic is sort of a referral from a psychiatrist. Now
Yes.
we've got a question here on best ways to kind of approach, because it's a bit more difficult than explaining if you're a trans man or a trans woman.
Yes.
Have you any
Listen,
advice there?
you know, yeah,
Yeah,
you know what I always say. Oh, sorry, Kat.
Oh no, I was just gonna say with it, like, I think it's the best option, because I work quite a lot with going through the referrals and stuff like that at the moment as well. I'd say the best option is making sure that vetting the fact that the therapist that you're going to is trans positive. That's the key thing that you want to make sure. If you're going to fork out for a private prescription, you want to make sure that your therapist is trans positive in the way that they are actually listening to the voices and perspectives of the trans people who are under them. So we find that, like, we've got a list on our site of different therapists we work with regularly, all of whom we talk with, we have MDT meetings with. They're very knowledgeable and they are extremely trans positive with regards to how they respect and treat trans people.
Yeah, yeah. It's not like you have to have 2 assessments because you're non-binary. You know, that's not the case at all. And you know, that's why, as Kat said, every 3 weeks we'll have MDTs if there's any discussions around patients. But you know, please, I always say to patients, look, just be yourself. Yeah, just totally, and just say it like it is. I always do it that way, and you know, I never get into trouble, and I seldom get it wrong for it. Well, no, I occasionally get into trouble, but but you know, I just, you know, tell us what's going on and we can help you. We've never failed to get a patient on hormone therapy and exactly what it is that suits them. But just be honest. Don't feel that you have to say one thing or another, or you have to, you know, present in any way. You know, I have patients that come in and they'll sit with a beard and they'll say to me, Mary, you know, I'll say, and how do you identify? And they'll say, I'm trans female. And I'm like, that's great. That's grand. Okay, so what's the process? What we're going to do here? What would you like to do? You know, it's not about how you dress or, you know, you might have to do that for work, you know, for a short period of time while the hormones are changing your physical appearance. But I mean, that doesn't bother me. I mean, if Ray walked in with a skirt on to work, you know, it wouldn't bother me in the least. I don't, you know, and maybe it's just I'm a wee bit cracked myself as well. So, you know, it doesn't bother me. I love color and, you know, and change and people expressing themselves, which makes them happy. I mean, why wouldn't that be a great thing? So please don't ever worry about how you present, you know.
I think
just be yourself.
I think what they're talking about here is more how to convince a psychologist or how to approach it when they're maybe not trans plus. And I have to say that I think that the only way to go about this is to be knowledgeable, to be educated, and to be able to explain yourself as a rational, intelligent human being. If you come in going, I don't know which way is up, well, they're going to give you a very different diagnosis.
Yeah. But you know,
to that.
you know, if you're going for a diagnosis, then go to someone who is a gender specialist, who works within the gender field, you know, and who understands it. Don't go to someone who's never seen, you know, or assessed a transgender individual before. You know, if they're a psychiatrist, well, yes, they know the DSM and they know the way around it, and it's different. But you know, lots of psychologists, it's not necessarily their speciality. Okay.
Well, I've never come
end up
across
needing
it.
a few different sessions, which will cost you a hell of a lot more. Yeah. So go to someone
simply because you're educating them. And also, please also be around the psychologist's point of view. When Kat was talking about a trans plus, there's a lot of psychologists out there who say that they work with trans patients, but actually they're conversion therapists under a different name. And so we want to be very careful. If anybody tells you you're crazy or mad and you're curing and they're right and you're wrong, you've hired the wrong person. You've hired the wrong person. Leave immediately. They're not going to help you. They're going to do untold damage. And we see this an awful lot more for non-binary than we do for anything else, actually. So don't accept that. You know, you are in control of your own life and how it turns out. And it's not going to be on the behest of somebody who has no understanding, is not willing to help. So absolute no to that one.
Exactly.
So
I've put in the chat for everyone a list to our website, and on there is we've got a diagnosis page where we've got a bunch of different therapists who we work with regularly, who we vet. We've worked with them for years, and yeah, they're extremely trans positive. They know what they're talking about, and they are respectful of trans people's opinions.
Yeah. And if you're watching the reporting of this, it's in the description. There you are. Sorry, right, go ahead, Jess. We have more questions. I'm just trying to line up again.
Okay, so this person says, hi, Mary. I'm interested in knowing if you provide Raloxifene for non-binary folks, whether you prescribe that.
Sorry, whether I prescribe
Raloxifene, I might be pronouncing that right.
Raloxifene. Ask
You've
that.
never heard of it. I can't say that you've got to
No,
prescribe.
actually, interestingly, I had a patient the other day was asking me about Raloxifene. You see, there you go. You see, I don't know everything. And yeah, I'll have to Google that and see.
Well, what is it? Do we know what Raloxifene is?
Yeah, it's a drug called it's a selective estrogen receptor modulator is what they call it.
Right.
But it's a treatment to prevent bone thinning, I think, as it's a more like generalized prescription.
Right. Yes. Okay. And it's not, is it something, I suppose we prescribe hormones to prevent bone thinning. Okay. So we generally would start with the normal. I mean, if patients have complexity, say if they, you know, like we've had patients who one patient had an orchidectomy for 7 years and didn't go on any treatment and ended up with osteoporosis, and we would refer them to a specialist for treatment of that. And, you know, at Exascan, it's not something we would regularly prescribe, because what you don't want to do is you don't want to suppress all hormones and then try and protect the body against possible complications. Yeah. Hormones are necessary, and they don't just do, you know, single actions. They have multiple actions. So it's not something that we would regularly prescribe. I'm always happy to have a conversation and, you know, do research. I mean, one of my poor patients has been emailing me about getting something from a compounding pharmacy for her. And I will have to contact the compounding pharmacy and do that. So I'm always happy to have a conversation. But, you know, we prescribe hormones for a reason. And, you know, if you just want to block estrogen receptors and, you know, and not take any hormones, and that's not helpful. It's not good for your body long term, because you're more risk of the early onset of chronic disease. Yeah. Which I wouldn't recommend for anyone, because these days we're all going to live longer. So you want to live, it's about quality of life, really, not quantity.
We've actually had in the Q&A someone has written in who is an endocrinologist in Toronto and provided some info on it. It is a something that they've started doing for patients with gonadectomy to prevent osteoporosis. But this way they typically get some estrogenic effect.
Oh, right. Oh, okay. So they've had like an orchiectomy, or they've had their ovaries removed, and they're giving them some estrogenic effect with the, oh, interesting. Okay. I would take their name, because it'd be nice to have a conversation with them about it again.
Yeah, I'm going to make a note. I'll send to you later.
Excellent. Thank you. See, we're always learning.
And we learned on the spot as well, which is even better. And thank you to our chaplain or person in Toronto who chimed in on that one. So very much appreciated. Jess, you've marked a question here as answered, but I actually want to ask it if I may.
Sure.
It's like, where did I see it here? Answered, yeah. Can you, oh, good Lord, I've forgotten it, not forgotten it, I haven't lost it here. The erectile dysfunction. Oh, yes. Is it, are there any, no, not that one. Where's the one
We
on
do
the
lots of
erectile
things live here.
dysfunction? No, the erectile dysfunction. So basically, is there a way to go on estrogen and not block erectile dysfunction?
Yes. Okay. Again, this very much depends on the individual. You can have some patients on estrogen alone and it will just block, okay, erectile function. I have patients on injectable blockers who can still maintain erectile function, okay? Very few. I probably, less than 5. So again, it very much depends on the individual. Like with any male, every single assigned male at birth, will experience different function at different, stages of their lives. But I have some patients who want to maintain erectile function, and that's absolutely fine. I have some patients who, want maximum feminization and will say, well, Mary, can I use Viagra for the occasions that maybe I want to? And, if there's no contraindication, well, of course, and if it works, and it does work for some of my patients, that's absolutely fine to do so as well. One size never fits all. You can never say to a patient once you start them on estrogen that, oh yeah, no problem, you're going to maintain erectile function, because I can't guarantee that. Again, I don't have that crystal ball. I cannot predict. But it is about finding what's right for the patient. And not all patients will want to have genital surgery. They won't, and they may want to feminize, maintain erectile function, and we can always manage a way to kind of balance their hormones so that they can, get maximum effect, whichever or whatever that may be. Yeah. So again, it's about having a conversation, and patients are often very good and very intuitive about finding what suits them best. Following a conversation, I can say, well, look, these are the options. Let's try it and see how it works. And let's get back in touch, have a phone call, in a few months' time and see how it's going.
It's also worth mentioning as well, with erectile function, stuff like that, it is also based on you can have like a greater chance at maintaining erectile function and stuff like that if you are and it's not accessible for everyone, but if you are using it regularly and stuff like that, you'll see less negative effects, as you're essentially exercising the muscle.
Yes.
So it's something that it's not as cut and dry as you can and you can't depending on medication. It's a much more complicated issue.
We've got a really interesting question from Flynn here. Is it possible to have changes plateau? So as in, if they wanted to become more masc, could they maintain that level of androgyny over time? Or as you continue taking hormones, you're just going to become more and more masculine?
I think you kind of reach, after a period on hormones, you kind of reach your maturity. It's like going through puberty, you'll go through it and come out the other end. I think continuing taking testosterone will maintain that change. Of course, if you stop certain things, of course, will revert back. But I don't think you continuously, it's like, we all change with the aging process, and our hormones help us to benefit long-term. Okay. So I think they're beneficial post the menopause, post the andropause, as I say, because we're all living longer. But, if the patient is asking, if I keep taking hormones, are things going to start changing? Well, you'd end up looking like a bear, really, with hair all over you if things kept changing that much. So no, you tend to go through your puberty and come out the other end, and there you are, really. Yeah. Would you agree, Ray?
Yeah, I would, but I have seen that going on a higher dose does increase changes. However, only to what would be genetically normal for your family. So if I keep taking testosterone, which I will, I'm not suddenly, as you said, going to turn out to be a hairy beast. We are a family that grows zero hair whatsoever. I use minoxidil to get this because my brothers took 10 years to grow their first hair on their face. And if I wait that long, I'll be retired. So no. But if you get to a certain level and that's it. That's it.
Yeah.
That's where you are. There you are. Right. You want to go to the next one? There's a few, I think, quick ones here as well, Jess.
Do you stop taking the pill once you start on testosterone? So this is female to male who takes it for period control.
I always say to patients, if they're very dysphoric about menstruation, to stay on it for 3 months. Yeah. Because again, you can't guarantee. I have some patients who will start on testosterone and they'll on transdermal testosterone because I start all patients on it and they'll never have another period. Okay. I have some patients 6 months in, they're still menstruating. But if you have a patient who's on the pill to stop the menstrual cycle and they're hugely dysphoric about it, the last thing I'd want them to do is to, start on testosterone, stop the pill. If they're just taking for menstruation, like not for contraceptive purposes. The last thing you want to do is start on the testosterone, stop the pill, and then having a period straight away. So I usually say to them, look, if you want to stay on it for the 3 months to stop menstruation, that's fine. But by 6 months, I'd like to know if testosterone is going to stop your menstrual cycle. So I want you to come off at about 3 months, 2 or 3 months in. Yeah, once you're settled a bit. Because if menstruation doesn't stop, then I would move on to Libido for my trans male patients. Possibly not for my non-binary patients, because Libido can masculinize pretty quickly. It can give you that, shove and jump that you don't need. So again, it's about having a conversation with the patient, how quickly you want things to change. So, yeah.
So do you have experience of, the use of DHT blockers for assigned female at birth non-binary people? Can this limit facial hair growth?
Yeah. It's an interesting one. We tend to prescribe the DHT blockers for patients. So we're blocking the conversion of testosterone to dihydrotestosterone. Okay. So we tend to prescribe them for patients with androgenic hair loss. Now, just remind me, sorry, go back, I'm tired now. It's been a long bloody day, up at 5 o'clock this morning.
Yeah, DHT basically will the use of DHT blockers when someone is on testosterone stop hair growth? I'm going to say no, because DHT.
No, not necessarily.
Yeah.
No.
I mean, DHT is what, too much DHT is what makes you go bald. It's what you lose hair with because it coats the hair.
Yeah. And we do have patients, we normally put patients who with hair loss who come to us and have already had some androgenic hair loss, we'd stop any further by putting them on a blocker. So blocking the conversion of testosterone to dihydrotestosterone. But those medications can have side effects as well. So we'll always start low. So we'd start with like finasteride 1 milligram or dutasteride 0.5 milligrams for patients experiencing androgenic hair loss. Or sometimes with my trans female patients, if they're experiencing hair loss, I'll block earlier, because what you don't want is you don't want more hair loss for them. Yeah. And natal females can have hair loss just like natal males can. So again, and the NHS don't prescribe, GPs do not prescribe for androgenic hair loss. So while they can prescribe 5 milligrams of finasteride for prostatic hypertrophy, they can only prescribe the 1 milligram that's recommended for androgenic hair loss on a private prescription. So sometimes patients end up paying, although I have to say GPs are very good about, trying to work around that scenario.
Yeah, it's good. I mean, I've only ever seen DHT, to stop hair loss. not to stop it growing in the first place.
Yeah.
You know, I haven't seen it used that way. And also, if you go for bottom surgery, which is not really the conversation here, you tend to go on DHT to make bottom growth as big as it could possibly be. It kind of ties into another question a little bit further down, but I'll let you just do them.
Yes, yeah, that's what I have. I have a patient
Yeah.
requesting a prescription from a compounding pharmacy now for something like that. There's a compounding pharmacy in the UK who will actually make up a prescription, and it is exactly for clitoral growth and that. So it'll be very interesting to do some work with them on that.
Yeah. Jess?
So we have a question, Cal Casanova, fantastic name for the record. An assigned female person, assigned female at birth person who gets top surgery and is on testosterone for a while. Is there a chance of, after stopping testosterone, that breast cells will redevelop and grow?
If, you know, if all of the breast tissue has been removed, then no. But some surgeons, to achieve initially a better aesthetic effect, they will leave some breast tissue because it'll mimic a kind of a pec muscle. Yeah, if you leave some of it there, you can get that kind of effect like you've built. The surgeons that we work with, LTC, don't believe in doing that, because long term then you still got breast tissue, you're still at risk of breast cancer. And also, you know, breast tissue, when it empties, you end up with empty moobs. And so it's not ideal. So I would say to anyone planning to have top surgery is, you know, if you're going through that surgery, what you should do is have your breast tissue removed and just work on building your pecs. Yeah. Because you do have the pec muscles there. Testosterone is going to, you know, increase them slightly, but you're going to have to work on them to do it. I always say to patients, there's no quick fix. You know, some patients will say, oh, but can I have fat pumped in to the muscle there? Well, when you build it, yes, of course, you could have that done to give a better aesthetic effect. But initially, it's much better to have all of the breast tissue removed.
I think their fear was if they stopped using testosterone, that estrogen would take over and the breast tissue would regrow. Only if there's breast tissue there. And
Only
I've
if there's
never
breast
seen
tissue
it.
there.
I've never seen it. I've never heard of anybody, you know, even saying that. But, you know, obviously it's possible, but it's highly, highly, highly unlikely.
Some quick fire ones we have. Is it true that progesterone is more likely to cause brain tumors? I heard that one before, actually.
No, actually, now it's progestin, the synthetic progestin. There's been some association because cyproterone acetate is a synthetic progestin, and you know you can have increased levels of prolactin. Prolactin is produced by the anterior pituitary gland. In patients, there's a very small risk, but there is a risk of them having a prolactinoma, which is a benign tumor of the pituitary gland. Interestingly, now we've had, and generally you'd put patients, say trans female patients, on cyproterone to block testosterone, but interestingly, we've had 2 trans male patients with prolactinomas.
Right.
I know, yeah, but they're easy enough once they're diagnosed, easy enough to treat, in fairness, and they just need monitoring, and they are benign tumors. So yeah, it's all about, you know, monitoring your patients and listening to them. And if they're not comfortable, they're not happy, they're having side effects and anything, you know, you listen to your patients, because they're not contacting you for the hell of it. People have busy lives. If patients contact you because they have a problem, you need to listen to them. Yeah, you need to find a solution.
Yeah, fair enough.
Associated with periods, this person gets miserable mood swings for a week beforehand. Is testosterone going to help even that out?
Oh, I wouldn't go on testosterone to get rid of my mood swings before my periods. No, I definitely wouldn't.
Would you not be more progesterone? That's not what evens things out.
Yeah, well, now you see, but before your period, you get a hike in progesterone. And interestingly, progesterone can have a very negative effect on some people. Okay. There are a small group of females who have a condition called PMDD, and they can end up wanting to kill you or commit suicide, either because of the increase in progesterone prior to the menstrual cycle. So although it suppresses the central nervous system and can have a calming effect, there is a small percentage of females who really don't get on well with it. So, you know, I wouldn't, if you're someone who, you know, if you're non-binary, transmasc, and you're going on testosterone, yes, it may help. Or if you're trans male wanting to go on testosterone, but, you know, if you're just going on it to stop, you know, your mood swings before, no, it wouldn't be the one.
Is it not more people go on the pill to sort of even things out like that?
Well, interestingly, if you go on the pill, you annihilate any hormones you're producing. I mean, I'm amazed that more females don't suffer with osteoporosis being on the pill for like 30 years, because you're not producing any hormones. Yeah.
Right. Well, maybe they do. It's just not studied.
No, I see their levels. I see their levels. Really? It suppresses your FSH and LH, and, you know, and nothing much happens. But it's an interesting one. And sometimes the pill has more of a negative effect. It doesn't stabilize anything, really.
Right.
Your
so what kind of person
for a
getting
reason? Your hormones
yeah.
are, yeah.
They are, but what kind of person that do? Is there anything that they can do to sort of even things out?
Yeah, you can. It's about lifestyle, diet, exercise. Yeah. It's about meditation. It's about yoga. It's about, you know, it's lifestyle changes make more of a difference than any medication when it comes to, you know, PMDD. And you see women going through the menopause, and if they're fit and healthy and they exercise regularly, then they don't get the awful symptoms that most other women will do. So lifestyle is huge too when it comes to, you know, symptoms around dysmenorrhea and painful periods and everything else.
Fair enough. So can I take the anonymous attendee, if you don't mind, Jess? Does hormones affect the ability to orgasm for FTM with no surgical transition? I want to tell you from the bottom of my heart that your libido will go through the bloody roof, right? You're gonna have to sort yourself out on a daily basis, or you won't be able to concentrate. What does happen, and I'm not joking on this, is that I guarantee you women have better orgasms than men, because female orgasms are the entire body. Male orgasms are centered in one particular area, and over time you will find that changes. Does it change your ability to? No, absolutely. You're going to have a great time. You know, if you're on a low dose, you may not feel the effects, but dear God, the full effect of testosterone, it takes some getting used to. It really does. I was surprised. I knew it was going to happen, but I was surprised. But no, it will not block your ability to orgasm in any shape or form. Not a chance.
Is there a way to block estrogen as an assigned female at birth?
It's a dangerous thing. Why would you want to block it? It's like trying to drive a car and not having any petrol in it. You're chugging along. Yeah.
I think they want to lessen the effect. Do you know what I mean? So.
But that should balance out if you're taking sort of testosterone, shouldn't it?
Well, it should if you're on testosterone, but if you can't get there or you're microdosing, it may not have the effect.
Yeah, if you're just as an assigned female and you want to block estrogen, then you have to replace it with something. Otherwise, you know, that early onset of problems that I was talking about, you know, that's a real thing. Yeah.
You don't want to get old early, that's for sure. You know, you're basically going through a version of the male menopause or the female menopause, and men get them as well. You don't want that. No. It's an awful thing to be going through. You don't want you'll age yourself enormously.
Early onset of chronic disease. Shocking. Yeah. You know, you literally just crumble slowly. So blocking estrogen long term is not a good idea.
Right. Okay.
Unless you're taking, you know, testosterone. And
yeah, well, then you're replacing it. It's like
you're replacing you're swapping.
There's still something in your body that's doing the job.
Yeah, you're swapping your hormones to protect yourself physically.
Yeah.
We've got a question from Ripley who asks, can masculinizing hormones, decrease pain tolerance?
Oh, we're talking about here with chronic pain and endo. So are we talking about fibromyalgia or something here? I don't know if they don't say. But
Fibromyalgia.
we're talking about somebody who already has a challenge, a pain challenge.
Well, they may improve because, you know, if you are struggling with a chronic disease or disorder, then taking hormone therapy may improve. Even if it's just improving your psychological approach to your illness or whatever. But with an improvement in your muscle mass and your strength, it may make my life easier. Yeah, well, especially when it comes to mobility issues. But again, as I say, lifestyle and exercise. I mean, I have patients in wheelchairs who are very fit and well, because, you know, they might be, you know, some of them have no motor function from the waist down, but physically their upper body, they exercise and they're strong, you know. So again, it is about lifestyle and exercise and trying to do as much as you can. But testosterone can make a difference, definitely to your stamina.
Okay, and then a question at the top here. So I suppose this is a broader question in terms of if someone is maybe later stage transition, they've had surgery, if they decide that they're moving to more of a non-binary space, you know, what's the sort of process there with your team?
Yeah, what surgery have they had?
Well, they've said MTF post-op, so I'm
presuming... All right. Okay. MTF post-op. All right. And they're moving to more of a non-binary. You're still gonna need, you know, you're still gonna need hormones. You're still gonna need your estrogen to protect your body, you know. But I know lots of females who aren't ultra femme who present kind of non-binary. So estrogen, it doesn't mean because you have estrogen you're going to be ultra femme. You can't present as non-binary. You know, of course you can. It doesn't necessarily, you know, estrogen doesn't necessarily make you more feminine, because you can present, your presentation can be that of non-binary. I mean, if I was to go around and wear suits and shirts like Ray does and a cap on my head, you know, especially as one gets older, we become more androgynous naturally. Yeah. So I'd easily, you know, pass as non-binary. I mean, I've had patients when I've had my hair cut short ask me what my gender identity is. And my kids will say to me, Mom, you just look like an Asian lesbian. Don't do that haircut again, you know? So it's very much about, you know, how you dress and how you present and that as to, you know, how you look as well. And you don't, I wouldn't say stop taking your estrogen, you're going to present less feminine. That's not a good idea.
Yeah, I think it's like it's a question of gender expression. Like, yeah, it's much more towards that. Like, as someone, like, my medical thing is on like full doses of estrogen with progesterone, but how I present is more butch and more androgynous in a lot of my clothing choices and my style choices and stuff like that, which can more affect how people will interact with me and stuff like that within non-binary spaces.
Yes.
Spaces, but yeah,
and how they'll perceive you. Yeah, for sure.
Yeah. I mean, I think a lot of that is, look, again, it's not what the outside world sees, it's what you see, it's how you feel. That's the most important thing to go for here, because there's always going to be somebody with a bloody opinion, you know, and someone is going to misgender you. And look, for non-binary, I'm sorry, there's probably a lifetime ahead of you where you're going to get misgendered, lifetime syndrome. Well, I don't even think that exists. And you've all that stuff to deal with, you know. So what's most important is that you feel good in yourself, that you're looking the way that you want, that you feel comfortable, that you're on levels of hormones that suit you, that, you know, is giving you the feelings that you know, make your life move in the way, you know, but remember that being transgender isn't everything in your life. It's one small part of your life. You still have to go to work, you still have to deal with your family, you still have to pay your bills, your taxes, and all this kind of stuff. So it's so important that you don't let your transgender identity become your only identity. You have to get on with life. It's a part of who you are. It's not everything, but you must be comfortable in who you are as a person. You know, and let's be honest, we're all jumping through a lot of hoops here so that we're feeling comfortable in who it is that we are. But the dress and how you appear in yourself is the number one thing. And you're 100% in control of that. 100%. Like another mini rant. Sorry about that, guys. So, all right. So look, I think we leave it here because we've gone, as usual, way over time. Thank you so much to everybody who participated. Thank you, Kat and Mary, for being here with us, for yet again giving us the wisdom of your experience. And you know, and I love the non-binary section here because there's a lot of questions here that we haven't had in either of the other two webinars, and that's absolutely brilliant. That's what we want, is to do things. Now, if you have other questions that either we didn't answer, or if you're watching this on the webinar and you have a question, put it in the comments box and we will get the question answered. So far, we haven't had anybody who's asked us anything that we can't answer, but look, we can of course get that for you. What I'd also say as well is, Mary, if anybody wants to get in contact with you, how can they do that?
Over to my expert, over to Kat.
Yeah, so I'm head of comms. I'd go to the website. You can submit an inquiry form. You can send us an email. We have all of our contact information on there. Drop us a line. We're always happy to help. We have a pretty tight turnaround with emails at the moment. So yeah, jump in.
Okay, so that's the genderhormoneclinic.com. Is that correct?
Yep,
genderhormoneclinic.com,
and our email address is info@thegenderhormoneclinic.com.
Okay. All right. Good stuff. Good stuff. Okay, super. So thank you so much. Again, if you want those details and you're watching the webinar, look down. It's all in the description. It's all there for you. Mary, thank you so much. It's wonderful. Kat, thank you so much. Wonderful. Jess, thank you for keeping us on track and, you know, prompting me when I was ranting and stuff like that. That's perfect. Always appreciate that. Keeping us on track, or we'd be here till 9 o'clock in the evening. But look, thank you everybody for being here this evening. I hope you got the answers. I hope this was helpful for you. You know where to go if you have additional questions and answers. But listen, thank you for being here this evening. We look forward to seeing you on the next one. And until then, please take care, enjoy yourself, and goodbye, everybody. So take care, everyone. Cheers.
Thanks, guys. Bye.
Bye-bye.
Bye.
Bye.
Thanks so much for watching. Please subscribe just so you won't miss out on anything we do. Thanks so much.
Bye.